agora a gente vai ter a participação do Dr. John Bissler, que é nefropediatra, chefe da divisão de nefrologia do Departamento de Pediatria da Universidade do Tennessee. Ele vai fazer uma participação online aqui com a gente, e ele é um dos grandes responsáveis pelos estudos clínicos com os inibidores de mTOR para o tratamento da esclerose tuberosa.
Good morning. My name is Dr. John Bissler, and I'm extremely grateful to have the opportunity to talk to you this morning about Tuberous Sclerosis Complex. I'm going to make my picture disappear so I can talk more effectively. I'm going to talk to you about the renal manifestations in Tuberous Sclerosis Complex, as well as the clinical practice recommendations that are coming out very soon in a good nephrology journal. So you don't have to take notes. You'll have all the information you need. My objectives this morning are to tell you about tuberous sclerosis, talk to you about the renal manifestations, and then give you these clinical practice guidelines, sort of just summary points. The manuscript will have a lot more information that will be very helpful, as well as the grading of the information. So what is tuberous sclerosis? Tuberous sclerosis complex is an autosomal dominant disorder that's affecting both fetal development as well as postnatal growth. Major neurological and developmental effects occur in most patients, and tumor development occurs in actually multiple, but really all organ systems. The birth incidence of tuberous sclerosis is about 1 out of 6,000, but it's not recognized by clinicians that aren't familiar with it, because fewer than 40% of patients will have the classic triad of the facial angiofibromas, developmental delay, and intractable epilepsy. Recent systematic review of tuberous sclerosis identified the leading cause of mortality as being really three things: epilepsy, status epilepticus, as well as sudden unexpected death in epilepsy, kidney complications, and complications from infections. But heightening the importance of the kidney involvement, 40% of adult patients with tuberous sclerosis have decreased kidney function, and the TSC-associated kidney disease is the most common cause of death in adults. Well, what are the major phenotypes in TS? Half the patients in most populations with TS will have renal angiomyolipomata. And I have an example here in the middle of the screen. Down at the bottom is you see kidney, and up at the top is this classical or fat-containing angiomyolipoma. And at least half the patients also have renal cystic disease. We'll talk more about that. As far as a renal cystic kidney disease, I've shown this picture. We'll take a kidney, we'll bivalve it so you see the vasculature and the renal architecture, and then we'll take away the vasculature. Now, the nomenclature, there's 5 different kinds of TS kidney disease that is cystic. The nomenclature is based on the location of the cyst, the distribution, the size, and number. Cortical cystic diseases include cortical cystic disease, where the cysts are these small cysts, generally the same size, in the cortex or columns of Burton. There's also microcystic disease that occurs in clusters. And what you see is cystic disease on MRI. You don't really see many cysts. You might see some, but you see in T2 weighted imaging too much water in the cortex compared to where you should see more in the medulla. There's also focal cystic disease, where there's clusters of cystic disease. There's also multicystic kidney disease that can involve all areas of the kidneys, including the renal pyramids. And you really also have this funny loss on MRI of the corticomedullary differentiation. And then there's polycystic disease, where very large cysts arise. Initially, they seem to come from cortex, but it's hard to tell. They probably come from everywhere. And it's associated with a contiguous deletion of the TSC2 gene and the PKD1 gene. The problem with this is that patients with TSC kidney disease are at significant risk for delayed or inappropriate health care. Patient groups have arisen to try and support patients and family, improve the knowledge of the disease and its care. And while there's updated recommendations for the diagnosis and care of TSC patients available, few explicitly provide nephrologists or urologists with information on kidney manifestations and management in TSC. There's lots of anecdotal reports of patients having unnecessary surgeries like nephrectomies, and this worsens the risk of advanced chronic kidney disease for sure, and especially given that targeted approaches like mTOR inhibitor therapies for angiomyolipomas, and although not approved, it actually works for the cystic disease with the smaller cysts. So let's talk about the clinical practice guidelines. We wanted to integrate the input from all the physicians involved in the kidney management of TSC. This includes nephrologists, urologists, geneticists, radiologists, interventional radiologists, and pathologists, as well as family and patient representatives. And we performed a systematic review with the most current and accurate information and put them together in a single source document so a nephrologist or urologist can go and find just what they're looking for. This group was through the European Rare Kidney Disease Network, also known as ERCNet. It was the working group on autosomal dominant structural kidney disorders. And it was also partnered with the European Renal Association working group on genes and kidney. There's a list of names. I'm presenting the work that we've all done, but this includes the family and patients, urologists, respirologists or pulmonologists, radiologists, and nephrologists, and you can see the distribution of where people came from and who they were. As far as genetic testing, it's really recommended for all patients with TSC, if possible. If no disease-causing variant is detected, but the patient definitely has TSC, then high sensitivity genetic testing is recommended if you can obtain it. If no TSC PKD1 deletion is detected in a patient who has very early onset polycystic disease, then high sensitivity genetic testing is also recommended to achieve a pathologic allele at an allele frequency as low as 1%. And we felt that that was very strong as far as the recommendation. But we don't recommend routinely performing testing on patients with just an isolated angiomyolipoma in the absence of other features because of how common just sporadic angiomyolipomas are, though they do have most often mutations in TSC2. When a pathologic variant is identified in a patient, we recommend expert clinical evaluation of first-degree family members, and we recommend genetic analysis of family members without features. I'm sorry, let me rephrase that. We don't recommend genetic analysis for family members that don't have any features. We want to make sure, though, that the genetic counseling takes into account everything for families and patients with disease who are considering additional children, and they should also consider the high degree of intrafamilial variability about the disease severity. Children and adults with TSC who have pathologic variants can have an overall greater severity of disease than patients with TSC1. And a second statement from the genetics group is that patients with the combined deletion of TSC2 and PKD1 have a high risk of accelerated cystic disease. We will have a flow chart to help sort of follow the renal disease for follow-up of blood pressure and kidney function both adults and children should have a good clinical assessment, as you would expect, with history and imaging, kidney function, and urinalysis. And then if their blood pressures are elevated, for children above the 95th percentile and for adults above 120/70, you should consider annual 24-hour blood pressure monitoring to understand where things are going. For high blood pressure, for both pediatric and adult groups, angiotensin-converting enzyme inhibitors or ACE inhibitors are considered the first line of therapy. Recommendations for diagnosis and monitoring of treatment of hypertension in the patients. Again, annual standardized blood pressure assessments critical, and we talked about the 24-hour measurements. Now, not every center has 24-hour blood pressure monitoring, so you can use home blood pressure monitoring as an acceptable alternative. And then we talked about ACE inhibitors and angiotensin receptor blockers for therapy. And then for children and adults with hypertension, the risk factors include advanced CKD, a high stage of angioimmunopathy, or the children who are treated with ACTH or steroids for infantile spasms. There's really no data to suggest that clinical practice for the management of hypertension in these patients should deviate from the current guidelines as far as the threshold treatment, except in the contiguous gene syndrome. Given the work from Robert Schreier in ADPKD, we'd probably use a lower threshold to treat. Also, we recommend an annual assessment for angiomyolipoma-related complications like pain, bleeding, blood pressure monitor, and biochemical analysis, annual blood and urine studies. However, in children without any imaging evidence of TSC renal disease, you can delay the findings even until adulthood. For patients with low muscle mass, for example, folks with intractable seizures or significant neurologic involvement, we don't recommend using creatinine to estimate the GFR. We recommend using a cystatin C-based approach like the CKID formula. If patients are going to start an mTOR inhibitor, we definitely think blood and urine tests should be done before the start of treatment. And in patients with the cystic disease with nocturnal enuresis, we really would rather avoid vasopressin analogs like DDAVP. We also would have you consider getting more frequent blood pressure and kidney function monitoring in the contiguous gene syndrome because of their significantly increased risk of involvement and complications. And we talked about GFR estimation would be good to perform, but there's no data suggesting it's different in TSC than it is for other kidney diseases. And there's no evidence that kidney stones or other cyst complications or infections should be managed differently. And then lastly, the patients with a contiguous gene syndrome should have a full clinical, biochemical, and radiological assessment at the diagnosis. What are the reported bleeding risk factors in patients? Symptoms, pain, hematuria, nausea, vomiting, may be associated with increased risk. TSC2 is thought to have an increased risk. Females seem to be more at risk. In sort of a middle age, 15 to 50 age range. And then angiomyopomas greater than 30 centimeters. And then definitely the highest risk factor is the presence of microaneurysms greater than 5 centimeters. And then also angiomyopomas with significant vascularity and especially exophytic growth. Well, when do you treat them with mTOR inhibitors? It's really the first line of treatment of angiomyopomas that aren't requiring urgent treatment. For patients, we also recommend offering those who have an increased risk of a significant bleeding risk. So how do you define that? Patients with growing an angiomyolipoma that's greater than 3 centimeters. And what if they're transplanted? Well, we would offer that you should consider an immunosuppressive regime with an mTOR inhibitor post-transplant to help keep the other aspects of the disease in check. What about kidney imaging? We recommend performing kidney imaging at the time of diagnosis. And really, MRI is truly the preferred modality. Now, in children, you can use an ultrasound if a radiologist is going to do the study and this radiologist is part of a cancer facility where they routinely image kidney tumors. Then this would be an acceptable alternative. But it's going to miss a lot of things. The fat poor lesions, for example, can be invisible. In adults, if you can't do an MRI, then a contrast-enhanced CT could be used, but you wouldn't want to do that frequently because of the risk of the contrast and the radiations. In kids, we recommend doing the MRI of the kidneys at the time of the brain. It's really not a big trick to swap the coils. It doesn't take very long. It doesn't add much time. So it's definitely doable. Most countries do it this way. And we recommend imaging for kidneys at intervals of every 1 to 3 years. And then we offer that you ought to adapt that frequency and so forth to the type of kidney lesion and the bleeding risk. And then if you're going to follow with MRI or CT or ultrasound, if you can get an ultrasound done and that's all you can have, that's fine. But don't mix and match the modalities because, for example, you won't be able to compare them accurately. So we've included here a flow chart in the document that's under revision right now. And really the branch points, are they bleeding? If yes, then consider radiologic intervention first, embolization, which is preferred, and no, then surgery or medical management if possible. If they're not bleeding, are they at a huge risk? If yes, then start mTOR inhibitors. If no, then keep evaluating them, regular surveillance. And then if there's no response to mTOR inhibitors, look at the dosage, look at adherence and the type of lesion. Consider alternative treatments if you need to. And if it is responding, then continue the drug. When do you really start? It's really the first line. mTOR inhibitors are the first line of treatment. Especially if there's an increased bleeding risk. mTOR inhibitors in all children and adults with a growing lesion greater than 3 centimeters. And consider, I think I've just said that, sorry about that. As far as the dosage, dose do you use? For adults, we really recommend 5 milligrams of everolimus, for example, as a starting dose. I know the studies, because I wrote them, used 10 milligrams because that was the highest tolerated dose. But in adults, 5 milligrams has been very effective. And in children, we use half the starting dose. We use 2.5 per meter squared. It's a reasonable starting dose and adapt it from there based on response. So you sort of individualize your treatment to the patient's response. And you can lower the dose or temporarily interrupt it if there's mild adverse effects, but you don't have to stop the therapy for good. And we suggest obtaining troughs in the case of safety concerns or adherence problems or lack of efficacy. And we wouldn't ever exceed the target trough of 15 nanograms per ml. Currently available randomized control trials examining the effects of everolimus on angiomyolipoma started at a dose of 10 milligrams a day for adults and 4.5. We recognize that, but we think lower doses are effective and can be started and reduce the risk of side effects. And the second statement is sirolimus is really a reasonable alternative to everolimus as an mTOR inhibitor. Well, how do you define a response to an mTOR inhibitor? And from an imaging perspective, you can have a reduction of volume, or you can get it to stop growing, or you can really slow the growth based on a multidisciplinary assessment. The radiologist, nephrologist, and urologist all agree it's an improvement, and you don't see any aneurysms. From a symptoms perspective, you sort of have to individualize that with the patient to see if the symptoms are controlled and that sort of thing. For fat-poor lesions, the imaging often a response that's important is you'll see a reduced volume or growth arrest, and sometimes you'll see a decreased vascular component. So how long do you treat, and what about discontinuing mTOR inhibitor therapy? In cases with response to mTOR inhibitor, we recommend to continue as long as the patient tolerates it and you're getting the effect you want. Once you start, I don't think imaging again in 3 months or 6 months is particularly valuable, because I've seen responses take as long as 12 months, and others have seen this as well. And so that's a recommendation: image no more frequently once on therapy than once a year. If there's been no response after a year, you really do need to understand, were they truly adherent, look at the dosage, and confirm that the lesion really was a typical angiomyolipoma. And you need to think about, well, what other options do you need to pursue? We recommend to stop or pause mTOR inhibitor therapy if a patient has an active severe infection or significant severe adverse effect, like grade 3 or higher. The side effect profile for mTOR inhibition in TS patients really doesn't seem to differ from the general population. What about recommendations on radiological or surgical intervention? Well, they certainly need to be offered for patients with hemorrhage or hemodynamic compromise. And it can also be offered including discussions of active surveillance with significant risk of bleeding if you can't use an mTOR inhibitor. Radiological interventions like embolization can be used for patients who don't have a response to an mTOR inhibitor. And we certainly recommend interventional radiology for hemorrhage or bleeding as opposed to surgery, because you'll lose less kidney tissue. For angiomyolipomas at risk for bleeding, we offer you can tailor what you actually need. It needs to be a good discussion between interventional radiology, urology, and nephrology. If you're going to do an embolization, the recommendations include to use corticosteroid prophylaxis to circumvent the post-embolization syndrome. And then this will sound perhaps a bit silly, but we really don't recommend routine nephrectomy for TSC patients who undergo renal transplantation unless it's absolutely required. For example, the ipsilateral kidney is so large that you can't actually get the kidney in, or the kidney looks like it may have a malignancy or something like that. And if surgery is considered the preferred elective approach based on the multidisciplinary, we recommend using a nephron-sparing approach. Try to save as much kidney as possible. And in cases without any suspected malignancy, enucleation is the preferred approach. The statement, as opposed to a recommendation, in cases with hemodynamic instability due to ongoing bleeding after arterial embolization, radical nephrectomy may be required, although it's extremely rare. What about biopsy in the management of renal cell carcinoma in patients with TSC? We don't recommend routine kidney biopsy in all fat-poor lesions. I did this 20 years ago, and all I found were angiomyolipomas, and the literature bears this out. We would recommend a biopsy if the lesion's growing more quickly than expected, and that's really defined as 5 millimeters a year, and or if they really don't respond to mTOR inhibitors, then something strange is going on, and a biopsy would be warranted. And surgical intervention must be offered for the treatment of histology-proven RCC for patients with TSC. We recommend to offer mTOR inhibition first as a first line of treatment for fat-poor lesions that are angiomyolipomas because they respond just as well as classical ones. And then the statement that the committee came up with is that treatment strategies for histology-proven renal cell carcinoma in TS patients, it doesn't really differ than the general population. But nephron-sparing strategies are really important because the other kidney is going to be involved and there's going to be an increased risk of chronic kidney disease. And we have some algorithms on how to approach the multidisciplinary care. This is where a TSC expertise center is really important to confirm the diagnosis. You have the genetic counselors, and you can tailor the physician coordination to the different systems involved, the different ages involved. And it's really important to have a multidisciplinary approach to this disease process. Well, I've talked on quite a bit, and I'll stop here for a moment to introduce you to Ina. She's my niece. She lives in Portugal, speaks Portuguese. But I'd also put out there that putting your foot in your mouth appears to be a family trait of mine. I've probably put my foot in my mouth, and I'm happy to answer any questions that you may have at this time. Thank you very much for your attention. I really appreciate it.